Hello, how are you? So, good day everybody. I would like to show you some new technologies that we can apply now, and this is a new and interesting technology that I will show with our new. I don't know if you listen me. Yes, yeah, listen. So ¿me están escuchando o no? Sí. I was not listening to myself. So I am using this technology to evaluate the shear-wave. It means this is a kind of elastography, elasticity, but this is an like FibroScan technology. So the idea is that this give you in kilopascal the measures, and what we do here is trying to have a good measure of the lesions. This is a pancreatic tumor, as I already mentioned. This is a big lesion, so probably it have some necrotic areas, and this is very important to evaluate what is happening. This patient have already metastasis, so this is 40, ¿cuántos años? 48 years old with liver metastasis and jaundice and weight loss and with this mass. So this patient smoked before? Smoke? Alcohol? So my fellows doesn't know from Romania. That is terrible. So this is not good. So um, first you can see here the shear-wave technology. So I mean it's like 7 in kilopascal. So the elasticity is 7. The normal is between 2 and 3. So this is a hard tissue, but not very hard like normally we see. We can see a lot of calcification of this patient, but this patient have the CI 99 measure. So the CI 99 is 1000. Huh? So this is important because we need to evaluate this patient. Okay, so now I will try to see the elastography, but the quantitative evaluation, the quantitative analysis, but the qualitative analysis. So it's not, you can see this is not so hard tissue, but probably because there are some area of necrosis in this case. So you need to understand when we have a patient with a pancreatic tumor metastasis and CI 99 more than the 1000, the probability of cancer is 99.9%. Huh? Probably I am wrong. What do you say? Daniela, no? So the elastography is not helping us. But now I will try to show you a new software that we can use. Why we can not use DFI? ¿Por qué no podemos usar DFI? Oh, maybe. So now I will try to show you a new technology This technology is for measure the microvascularization of the tissue. So we can see this will replace in the future the bubbles, the contrast enhancement, and the idea is to evaluate if this patient have some kind of microcirculation in the lesion. We can see here some small vessels. I will show you here, but there is not microvascularization inside the tumor or neovascularization. This is normal vascularization. This is a small vessel inside, but this is the tumor, and there is not vascularization. So this is the DFI technology that we can apply also, and now we can see that. So we need some studies to compare with contrast enhancement, and in the future the idea is this will replace for sure this will replace the contrast enhancement and the CHA evaluation. So now we have already FNB of this patient. Okay, so now we'll take a biopsy first, and then I will try to, yes, I will use one of the best needles also worldwide. This is a Boston Scientific needle, very good needle. This is that Quire. So the idea is to have a good tissue here, just you know, to confirm the diagnosis, and the idea is to perform a biliary drainage to perform a comfort in this patient. So this is what we will do now. So you can see here the mass. It's a big mass. I'm sorry, it's small. You can see it here. So I will measure the mass. Seven by 6. It's a big mass, okay? So we already know. I invite you to see our paper or abstracts during ASGE days, and also in DDW. About radiofrequency in pancreatic masses and adenocarcinoma, and there is not benefit of doing radiofrequency in patients with metastasis. So I believe it's not a good idea to do any kind of another treatment for now that we have the first results. So now I am inside the lesion, you see, and now I start to do. You can see very well the needle here, very well. I am using a 19 gauge needle like Quire, and we need some tissue just to perform a confirmation, and after the drainage to see if the oncologist department will start a treatment for this patient. So one of the discussion is about to do a standard ERCP and to perform and to put a metallic stent in the biliary tract. So there are some papers already published that show some kind of interesting results regarding to perform by EUS directly, because we can have easier and faster technique, and also less radiation. However, this is still controversial, I believe. To my opinion, I believe we need to change. We need to start to drain more the biliary tract to see, because in some patients we can come overall those patients with downstaging, and we can try to do some kind of treatments like biliary drainage. So this is a very good, I believe, very good. Let me see. Let me show tissue. Very clear tissue. You see. We have a stake, I believe. So this is enough for me. When I have this, I use a 19 gauge needle. So for the pathology, it's very good. And now I will use. I will perform a biliary drainage. I need to perform. You see here. So the gallbladder is also, full. And this is the biliary tract. And so now I will do a drainage of the biliary tract. You can see I can use an Axios 10 by 10, I believe. But I will use Axios for biliary tract drainage. That is a small one. El pequeño. Quiero una aguja. So, and one of the tips that I can give you always is much better. Que uno de ocho. So it's much better always to use a guide wire, because you can avoid complications. And for biliary drainage, I believe it's much better to use, by my experience, I am not an expert, but I believe it's better. So now you can see here the biliary tract. No, guiado. Necesito una aguja de 19 estándar. So I will use a 19 gauge needle. Yes. You can use a standard guide wire needle, and then you will pass the guide wire inside, and once you are inside, so you can see here the stones in the fluoroscopy. I have my new fluoroscope. Very good. I love it. It's good. Yes. See. So now when you are stable, yes. So I will use for the drainage, biliary drainage, this is an Axios. What Axios? 6 by 8 millimeter. And to show how to do it. So first, to my opinion, it's better to confirm that you are inside the biliary tract, to do an aspiration and to pass a guide wire. It's more sure for you. Always. Even if you take a little bit more of time, it's not a lot of time, but it's sure. Daniela agree with me. That's correct, Daniela? Yes, she said yes. If Daniela do not agree, I will not do it. But she agreed. So I have two fellows, one from Spain, one from Romania. What they said, look, oh, this is green, huh? Really green. You see, like Hulk. So now I am the biliary tract. I'm sure that I am the biliary tract. I will flush with saline solution. And I will pass some contrast before to start, just to see that my drainage was good. It's not necessary, but I prefer to do it. And in some patients, for example, that have allergy to contrast, you can do a biliary drainage directly without using contrast. What do you believe, Daniela? Is better or not? For those kinds of patients that have contraindication for contrast, iodine contrast. when I do an IRCP, I need to do contrast. But what happens in those patients that have contraindication to the contrast? It's better that you can do a drainage using EUS. So I am inside the biliary tract. You see, it's a complete obstruction. So I will do my drainage now. You can see the image of fluoroscopy. ¿Puedes aumentar la fluoroscopía, por favor? So you can see the fluoroscopy image very clear. So now I am passing my guide wire. I am inside, I believe. Yes, I am inside. Empuja. So this is very important to see your guide wire when you are doing this, because you have to see the vision, the direct vision of the guide wire through the EUS. It's very important. So my technician is pushing the guide wire. I'm retired. The needle, and now I have my vision. You see here? This is my guide wire. So I'm sure that I am inside, and now I will use the Axios to drain the biliary tract. Very important. So now I am in a good position now. So I have my Axios here, and now I have my Axios looking inside. Okay, I will go. I am inside. I am perfect now. I will start to open. You can see here the Axios is inside the biliary tract. This is very important. If you see that it's inside, now you can finish your work. Ten aquí. Okay, now I will open my Axios and I will push a little bit to see from the other side. So at the endoscopy is going well because I can see the the bill is coming. And at the EUS also I can see very well here. I need to show you this. So this is the inside the lumen. This is the Axios here, the flange, and this is the other part inside the biliary tract. So it's perfect now. My deployment was good. I can see also my deployment very well by endoscopy. You can see the image there. So we finish. So this patient will be relieved of his problem of the jaundice, and and I believe there is communication with the gallbladder, so probably the gallbladder is not necessary to perform a drainage. So we do choledochoduodenostomy guided by, oh, you see, PUS by EUS. So perfect. So I finished my transmission. Thank you so much. Now we do just an aspiration, and I will finish. Thank you for joining us, and we invite you. There is a live endoscopy course of Professor Cajale from New York, so we will stay with him doing some cases, some therapeutic cases. April 5, please don't miss that. It's for free registration, epic. So see you soon, see you on April 5. Thank you so much for your attention, and continue to support us. Bye bye. Cortamos la transmisión, ¿no?